Living Room Logic.
Hello everyone, welcome to another episode where we're going to have a really interesting conversation today. And it is about COVID-19 again. But I think one thing that's really interesting and one thing that we can all share about COVID-19 is that throughout the pandemic, one of the hardest things to work with has been the uncertainty and the being unsure of what is to come. And that's what makes today's conversation with Professor Cathal Walsh so interesting, because it's his job in part to contribute to forecasting what may happen. Professor Cathal Walsh is the Chair of Statistics in the Department of Mathematics and Statistics in the University of Limerick, and he's a member of the Irish Epidemiological Modelling Advisory Group to NPHET. It's part of his job to help produce these models, which NPHET base some of their recommendations on. Would that be correct to say?
Yeah, that's fair. So they're a tool in terms of planning, I guess, anticipating what might happen and when. So
brilliant. So the first thing, just to kind of give us an overview, is could you describe in general or give us an idea about what exactly a model is and what the goal of modeling is?
Sure. So, I mean, there's one could take a big step back and talk about mathematical modeling in general. And it's used in all sorts of walks of life, everything from engineering and industry, process control, for example, through then to the particular area of disease modeling, which has been my area of work really for certainly the last 15 to 20 years.
Wow.
And in particular in disease modeling, one may be interested in everything from the progression of a chronic condition. For example, one could be interested in arthritis or multiple sclerosis or infectious diseases. And of course, COVID is an infectious disease, but similar models are used for flu and for HPV and for hepatitis and so on. And they're used in a number of different ways at present. Obviously, we're trying to say something about the trajectory in terms of number of cases, look at possible interventions. So they could include things like vaccination and treatments. And we can say something about the likely impact of those on the pandemic itself.
So that's really interesting that you went into so much detail with the modeling and that there's such a history of research and literature around not just infectious diseases, but also the pathogenesis of different diseases. And what I guess I'm wondering right now is how much detail do you actually get into the modeling? Because it's so complicated. You can't possibly predict everything. Like you can predict things like maybe the severity of the virus or maybe its incubation time. Maybe you can take estimates of vaccination status. But when you're looking at things like people's social behavior, is that worked in? I guess the only other thing I'm wondering is this something which is in the literature or is it something that the team puts together?
Yeah, so it's, I suppose you see there are different levels of model and a good analogy is with something like fluid flow or weather prediction, that one may have a quantity such as temperature, which is essentially an average value representing the amount of energy, I guess, in the air and the environment. And for when we're doing disease modeling, we're concerned with average levels of transmission. So even though one won't have enough information to be able to say exactly who will interact with whom, one can say something about the average level of transmission in the population. Each of us, if you like, has our own value of or our value beta, which is to do with how transmissible each of us is. But what really matters is the average across the population. And we've known from quite early on that there are some cases where a large number of individuals are infected, and there's other situations where no one seems to be infected. And in fact, it is the case that the vast majority of people won't infect others, but occasionally you get these very large outbreaks. There are other forms of modeling as well, and one of the models that we use is something called an agent-based simulation. And that does go into some detail about interactions between people and people of different types and so on. The age cohort model as well is somewhere between the agent-based simulation and the SEI or population level model. And that allows for different mixing patterns in different age groups and then mixing between the different age groups. So there are different levels of sophistication of the models. At the top level, the population average one, while it's not realistic, gives us certainly reasonable, very, very good predictions for the level of sophistication of the model itself. In terms of estimating the parameters, yes, so there's a lot of work goes into that. And some of them, certainly at the very early stages, that we didn't know anything about, when people became infectious. We didn't know how long it was from exposure to when someone is infectious to when someone develops symptoms and so on, and how long the disease would last. But over time, and with a bit of observation, we started to come up with estimates of those quantities. Even now with new variants, it's very difficult to know what those parameters are. And so in some of our scenarios, so for example, the relative transmissibility, we run different scenarios with different estimates of relative transmissibility. And each of those then results in a trajectory or a curve. And very much it's unknown as new variants arise. But over time, we do get to discover what those quantities are. So really the level of detail that's needed for the population level models isn't as much. It's really about the population average behavior than the micro interactions that different people get up to. The other side of it, of course, as well is, and I know people often ask, well, how do you say how effective masks are and so on? The only bit that matters is that it affects the transmissibility, and so there might be a reduction in overall average transmissibility when an intervention like that is put in place. But because of the way in which interventions are introduced, often we can't separate out the effect of the different interventions. So a lot of these are still unknown, if you like. But we do have enough experience to say that as a package, the measures that were implemented does have an impact on transmission of the virus.
Cool. So you can kind of like retrospectively look back and see how effective different groups of restrictions may be. I'm just kind of curious, do you have any examples of some of the parameters that are actually put into the model?
Yeah, so the key parameter is this beta parameter, and people might have heard of the OR number, and that is the transmission of the virus across the population. There are other quantities in the models, and one of the challenging ones really is this clinical fraction, which some people refer to as the documented fraction. So that we know, and at present we've got a lot of pressure on the PCR testing system, but even when we don't have pressure on the PCR testing system, we know that we don't detect every infection that occurs, and so this fraction matters. And the reason it matters a lot is because when people are infected, gradually what happens with any epidemic, you can see this exponential growth at the beginning. But as people become infected and are removed from the population or become immune, then the virus can't transmit anymore on that population. So the total number of individuals who have had the infection matters quite a lot. And we're not able to directly observe that. But we have done studies called serology studies, where we've looked at the population, a sample of the population after the first wave. And we noticed that, we were really only detecting 1 in 3. We were only documenting about 1 in 3 infections as registered cases for the first wave. At present, and when testing is under a lot of pressure, then it falls back to around those levels, so about a third of cases or so, perhaps a quarter of cases are detected. But when we have in peacetime, if you like, so earlier in the autumn, perhaps, we probably were detecting 50 to 60% of infections. And that's a parameter that really matters and that people can relate to as well. And so those key ones are transmission, how transmissible is the virus, and then the other one being the clinical fraction, documented fraction. And that has an impact on the trajectory of the epidemic.
So, that's really interesting. And it's interesting because my next question was actually, is there any parameters that you don't have that you think would be very useful? And I'm assuming that's probably the biggest one.
Yeah, that is the one that we'd like to get a better handle on it. And the only way to do it is to do those serology studies. And that's complicated now as well, because we know that the Omicron variant is quite transmissible, is the first observation. And the other is that it evades the immune protection. So whether that's been from vaccination or whether it's been from prior exposure to disease. And so if someone has previously had, alpha, delta, or the wild type of the virus, they can still get Omicron again. And so our serology studies tell us about the proportion of people that have been infected, but won't distinguish between the variants. And so to know how many people are susceptible to Omicron would be very useful. And that's a very difficult thing for us to ascertain. But we do know something about the rate of spread on the population, so we can say something then about the likely fraction that has been infected. historically, and that tells us something about the rate at which the virus will spread in the population. Initially, a naive population, the virus spreads really quickly, but as people get more and more people have been infected, it slows down, and that's how epidemics die out. So it's not necessary that everyone will have got the virus, but a sufficient number will have got it so that it doesn't spread across the population anymore.
Okay, and in the models that are put out there is the downward push, and is that because of things like the projected impact of vaccination as well as the infected community? So is like vaccination put into it as well? Because I think I was reading in the CMO's latest letter that there was an assumption that we would have something like 50% of adults at least boosted by the second week of February, something like that. And is that a part of what is predicted to push it down?
Yeah, it is. It is indeed. Yeah. So the effect of vaccination and it's not. I mean, it's. I think people are starting to become aware that vaccines work in different ways.
Mm-hmm.
The key benefit of vaccination is that it allows the body to get used to the pathogen, and so that the body can tackle it if you're exposed to the virus subsequently, so that people don't get as sick once they're vaccinated.
Mm-hmm.
The other thing that vaccines do, and they do it to different extents, is to prevent transmission. And unfortunately, we see that the Omicron variant is readily transmissible even in a vaccinated population, but the benefit of vaccination to the host, to the person, is strong in preventing more severe illness. The impact then, in terms of the modelling, is that it enters the model in two places. So it enters in terms of the transmission, and that will have an impact on the number of cases. So even though it's not perfect in terms of preventing transmission, it does reduce the rate at which the virus is transmitted. And so that has this downward force on the number of cases. And the second place it comes in is in that link between cases and hospitalizations and more severe outcomes, be it ICU or mortality.
Okay, and that's really interesting as well. And one thing, we briefly touched on it already, but I'm trying to get a measure of how the impact of the restrictions are put in, and is that kind of put into the modelling? So I know in the latest modelling it was shown along the lines of if socialization decreases 10% or increases 10%. And is that consistent throughout? So the modelling assumes that these restrictions, or perhaps the people who put in place the restrictions, are saying, we think that this might have a 10% reduction, and we're hoping to get that to hit one of these output scenarios from the modelling?
Yeah. So ideally, what one would like to be able to do is to say that we know such and such an intervention will reduce transmission by this amount. In practice, we don't.
Yeah.
We don't know, and it's something that at the start of the pandemic, certainly last spring, 2020, it seems so long, but so recent in some ways, is that we were trying to unpick and say, well, how effective are these interventions? Mm-hmm. Now we know that the total separation of people, so effectively what was termed lockdowns, we always knew that would have a very strong effect, but the problem is getting back out of it and figuring out how is the virus transmitted and what settings are going to be safe and what settings are less safe. But in terms of the modelling, all it impacts on is this level of transmission. So this transmissibility, so this beta, if you like, or this effective R number. So as we bring in restrictions, we're reducing the effective R number, or reducing transmissibility or transmission. To what extent, we don't know, and that's why we run different scenarios. If we had an increased transmission, if we had reduced socialization, this is the trajectory that the epidemic would follow. So really, we don't, and I know that can be frustrating for people. We don't have a definite amount that masks cut transmission by, or that social distancing cuts transmission by. All that matters is the value that's used for transmission, and that fits into the model. Now, we do explicitly put in the impact of interventions into the agent-based type simulation, but not into the population level or the age cohort models. It's really only the level of transmission that matters, and we shift that, and we kind of say, well, if we were to increase transmission, what kind of trajectory would the epidemic follow? And you can see historically as well, you can see that sometimes the trajectory of the pandemic follows some particular model scenarios, and sometimes it doesn't, and there's some scenarios where it doesn't track them at all. when we look back over time. And sometimes it's after the fact we kind of say, oh yeah, okay, so track this. A good example of it was this question around the relative transmissibility of different age groups, and we ran different scenarios where the virus was more transmissible and less transmissible among children versus adults, and the data tracked a trajectory where it was slightly less transmissible among children, less transmissible than adults, but as we know, Delta among everyone was much more transmissible, and so the transmissibility among children was more than Alpha was and the wild type was among adults, but there still is that age gradient. And in fact, we're seeing what happened was that we noticed that because there was vaccination in people over 12, that there was a reduction in transmission in those age groups, and the highest transmission were among the 10, 11-year-olds. But there was a gradient then with other ages. Because the new variant evades immune protection, what we're seeing is that age gradient coming back again. Okay. So the numbers in children relative to adults is in fact, they're falling. And the reason for that is that no one really has protection to the extent that they did previously. And so we're rediscovering that age gradient. So whereas people might say, oh, well, it's the schools are out or whatever, we expect that with a new variant that evades immunity, to see that age gradient occurring once again.
Yeah, I think I get where you're coming from, but it is very understandable for people to be concerned. Like I think of all the cohorts of people to be concerned, parents are probably the number one, and I think it is fair enough for them to be very concerned. I think you also kind of bring up something that I've been trying to communicate as well, where if we have a variant that's 4 times more transmissible, it kind of says that our restrictions in the past might be 4 times less effective on preventing transmission, which is another, complicated thing, because even though we are in so much a better place than we were 12 months ago, infinitely better, we still have some restrictions, and it's not really a result of the vaccines or anything like that, but it's more so a result of the new variant and it being more transmissible. So obviously you have an impossible job. Obviously, if you're trying to predict the future based on any amount of data, you're going to get stuck. And I think a lot of the time, what I've been reading is that, and what I'm understanding from speaking to you, is you're projecting scenarios based on values. And you're saying, if this virus has this much immune escape, this could happen. If it has this much immune escape, this could happen. And you can even see in the other models, they assumed that it had the same severity as Delta, because we didn't have the information at the time. And we're kind of seeing that Omicron is maybe less severe, but maybe too soon to say that for sure. But it's definitely trending that way. And I get the scenarios that you're putting forward, but I'm not sure if it's been very well communicated, because I think a lot of the way it's been communicated is, this is what will happen. It's like, this is exactly what will happen. But what you're saying is, in this exact scenario, this is what would happen. There are a lot of comments and discourse around it. But what I'm wondering is, since these are the scenarios and they're not going out into the future and you don't have a crystal ball, I'm wondering how much it is these scenarios are used to influence decisions that are being made. And I'm wondering if this difference between producing a possible scenario and predicting the future is maybe in part miscommunicated to the public, but this is not something which is miscommunicated to government, and they're very much aware of it when making these decisions.
Yeah, so I think you're right to highlight that. What you've made quite clear is that these are projections, if you like. They're scenarios. They're not predictions as such. And now, if we put in the right parameters, if we happen to get the right parameter set, they are essentially predictions. But in practice, they're not. The other aspect that you're highlighting there is that it may change behavior, and therefore we don't end up in a position where we don't want to be. But using these tools alerts us to the fact that this is coming. And in the case of the Omicron wave, we could see it happening in the UK. We were alerted very early. So back at the end of November, late November, we became aware of this variant. And indeed, in terms of severity, the emerging evidence, in fact, is that it is possibly around 20 to 25% less severe. So it's not much less severe, but what we have is an experienced population. So the impact at a population level on average, if you like, could be a little bit less, but because of the massive number of cases, we're quite concerned that will make a difference. But when we ran the models, and it was a stark realization that, oh my goodness, these could be very big numbers that we're looking at. But it allowed us to do things like to share with colleagues within the HBSC so that we could plan work rotas, and we could plan for people to be available if needed. People could recognize that this was going to come at us, and it has, and it is disconcerting when we see numbers increase like that. But we are aware, so the models allow us to say, where are we tracking? What are we tracking? Well, this is this is not entirely unexpected, so it gives us a reassurance, if you like, that this has been considered, this has been factored in. We saw the action that was taken by government early on to perhaps try and slow down the spread somewhat, and also the discourse that's there from the CMO and Minister today, highlighting that this is quite concerning. The numbers are going high. It is tracking at a high level on the scenarios that were fitted. But we do have, it's like having a map of the terrain. So it allows us to find our way through what otherwise might have led us to become extremely concerned and panicked, if you like. But we fitted the model. Now, when we first saw the models, it's like first seeing the models in March of last year. I remember it was February. So I gave a talk at the RCSI. We're hosting the Sphere conference. Gave a talk there, and from the discussion there with other public health people, and we had a conference in Limerick. So then public health actually were all out at the conference because it was around social determinants of healthcare. I ran my own models, and you could see straight off. You could see the curve going up. And you're like, wow, that looks like it could have a major impact. And it was about 2 weeks after that we ended up shutting down because we had the first cases in that, and that the modelling work took off really with groups from across the country. So it was a very fast reaction time. But we have in Ireland, we were lucky to have a network that we were able to connect up people quite quickly, and so we had people involved in statistics and math modelling and computer science getting together, with a lot of very good epidemiology coming from, in particular, experts in veterinary medicine, which is in veterinary medicine they're quite used to dealing with epidemics. In fact, so from a planning point of view, so their expertise is very good that way, and we're able to, and so it's from like those in the veterinary school who were able to contribute to our estimation of the parameters. So they knew what parameters we needed to find out, and we're able to get through the evidence and identify sensible values for those parameters. In fact, it was a miscalculation of the serial interval in the UK that led them to delay opening up. So they misjudged it a little bit, and so it took off more quickly than they'd realized. And they should have locked down earlier, but they didn't. And so it's mistakes in estimation of the parameters that can, that will have that impact, because they didn't recognize that it was going to take off quite as quickly as it did there.
Of course. And I think going back to, it's totally understandable how these small differences that can't be foreseen can kind of come in and make the models harder to communicate, for sure. And especially kind of saying that the model that you're putting out, it could be 2 weeks later and one of the scenarios is immediately off the board. It's you learn something and immediately this isn't the one, and it's very tricky to do that. And just going back, this is communicated, maybe this is miscommunicated, and I hope the people listening to this maybe get a stronger grasp of it, but it is clearly communicated to government and things like that. They're gone through the modelling. I'm sure they're sick to death with these kind of meetings, I'm sure.
I imagine they are. I wouldn't. I wouldn't want to suggest too much, but I mean, look, it can be. I think it can be difficult to see sometimes these really big curves, and then kind of trying to say, well, where are you getting this number from? But there have been a number of occasions where we had projections that went quite high and they haven't materialized. We've had other cases where, as we have now, where the reality is tracking at the higher end, if you like, of some of our scenarios. So, but they're there as a tool to sort of to facilitate discussion, really, and consideration of what might lie ahead if, for example, we do nothing. And then, of course, when we do something and then the high scenario doesn't materialize, people say, well, oh yeah, we locked down too soon. You know, we didn't have to lock down.
Of course.
But there is that dynamic that goes on there. And of course, people involved in the modeling don't have a vested interest in making stuff look bad. We're trying to get a handle on what's happening as well, and seeing it before it arrives is one thing. Trying to communicate it then, sometimes, if you're the bearer of bad news, is a difficult ask. And so that discussion generally wouldn't happen so much within the group. So the group involved in doing the modeling work aren't at the table with decision makers so much. I mean, that's done by the CMO and by others in the group, perhaps the chair of the group, and that communicated to the decision makers.
Okay, that makes perfect sense, and I totally get that. And the last thing I want to ask you about is, as far as I can tell, and please tell me if I'm wrong, but it's much easier to model now, maybe because you have a history of data to kind of calibrate the model that you're going with, but also it might be easier to model into the short term as opposed to the long term. So you might be able to better predict what happens tomorrow rather than in a month. So I'm kind of wondering, because I've seen a few people talk about this, but would there be any downside to updating these models or releasing them more frequently and kind of saying, we are seeing this, so this is the expected change, or maybe to kind of guide people into what they're expecting? Because I think there's a huge amount of uncertainty and people are really holding on to anything, any solid piece of information. And I of course, I know that the scenarios and the models aren't promises. They're not at all of what will happen. They're just under these circumstances. But even just guidance of saying we're leaning more towards this scenario at this point, perhaps beyond it, perhaps adjusting it. So is there any downside to releasing perhaps updated models as time goes on?
I hear what you're saying, and you're quite right to highlight, and that's typical of any modeling, actually. That's it's true for weather forecasts. It's true for many other models, that the near predictions tend to be easier than the longer term predictions. Mm-hmm. Now, what I would say though is that when you get high levels of transmission, it is actually fairly that curve is much more predictable than when you get low levels of transmission, because there's more randomness when you have low levels of transmission than when you have this very high rates of transmission that we're seeing at present. You're right, we could update those models, but I mean that comes at a cost, and the majority of people involved in the work are working in universities, for example, and that's who's funding us, and the funding doesn't come to the model. So we still have proper other jobs as well.
Okay.
So there is that cost in terms of people's time is one aspect.
Yeah. Of course.
It also often, while it can tell us what trajectory we're going to see in the near future, unless we're informing or we're going to make a decision, then that in itself isn't useful. And that's a hard thing. Okay. That's a hard thing, I know, to recognize. It's a bit like it's like any test, any testing or any projection or any diagnosis that unless you can act, unless you can do something, really that information is just it's just information, and you might want to know it and you might want to find out, but unless it's going to influence how you're going to act, then it isn't that useful. So those are the two aspects. One, there is a cost associated with updating models, and the second is this: unless it's going to impact on a decision that we're going to make, then it's not as useful to have the models. That said, there are a lot of very good people who are tracking what's happening and have summarized our models and taken our models and plotted the data onto the projections, if you like, and that can provide a lot of useful information for those who are interested in finding out more or hearing more. I think some people are just sick of hearing numbers, So
oh, for sure.
So maybe not everyone wants to hear more numbers or more projections. But there are
maybe once the wave is over, just release a model showing a hard downward turn, and everyone will love you forever.
That's it. Well, I mean, the letter to I think the letter from the CMO to the minister, it does that. It does provide us with that people can go and look at that letter and see what the rationale is, and but it's there. You have to click on the links. You have to go off and find it. It's not in people's faces, so that we're not. I think people are kind of sick of it at this stage. I mean, it has been 2 years, and at the start of the pandemic, I was asked the question, how long would this be? Will the schools stay closed for? And I said, yeah, they could. And they said, well, will it be weeks, 6 weeks, or a month? I said, well, it could be a year. Yeah. It could easily be 2 years. And I think that's a reasonable time frame to think of in terms of the pandemic. What we've seen with previous waves is that because the population gets more experienced in terms of dealing with knowing how to deal with the disease, and also because people have been exposed to the disease, their immunity is strengthened. That with this wave, and this is a very challenging wave that's coming at us, but would be optimistic that this is, that this will provide additional protection to the population. And what we're perceiving as mildness of the illness is because of those two things. It is slightly milder, but as I say, perhaps 20-25% is the estimate of how much milder it is. But because the population has been previously exposed to similar disease and have been vaccinated, the impact will be less than it would be at the very start of the pandemic. So that's the optimistic side. Not to downplay, this is going to be quite challenging these next few weeks.
Of course.
But you can see from the models how quickly this rise is projected to occur, but how quickly it comes down again. And we've seen that in other countries as well. And that happens, so flattening the curve protects the system. But if the curve isn't flattened, and it's very difficult to flatten the Omicron curve, you get this sharp peak and it comes down quicker again. Yeah. So that's the optimistic note. Not to downplay that we are looking at a couple of weeks ahead. But 2 years from when this all started would be March. And so it'd be optimistic that once we're through this wave, that would be in a better place.
Absolutely. And I was speaking to Killian de Gascoigne as well, and he was kind of saying the same thing, and he was kind of saying he can't wait to just kick this virus into just another seasonal coronavirus that is just another name in a list, as opposed to something that's consistently
and we see, and people, we're colleagues in the HPSC with the Health Protection Surveillance Centre, they're dealing with lots of different viruses and
of course
conditions, and so you're right that that's where we're going with it. And then no one wants to hear from modelers again, perhaps, but we'll be there in the background working on the other diseases that we work on anyway, whether it be everything from HPV to hepatitis to PCV to lots of other diseases. Of course.
Infectious diseases aren't going to disappear anytime, as long as there's people socializing.
Not at all, but it does shine a light, shine a light on the inequity in the world as well. It does. I mean, malaria, for example, is a big killer of a disease, but perhaps we haven't focused on it because it doesn't affect richer countries to the same extent as it does other countries.
Yeah, and we have seen that a lot with COVID-19, that it does tend to hit a little harder in perhaps richer countries with highly dense cities and things like that. And that's a good point. Thank you so much for your time and your work. I'm sure it's mostly a thankless job for the most part, and I'm so glad to kind of get an opportunity to speak to you and to kind of make it a little clearer, and I think it'll really help everyone who's listening. So thank you so much, Professor Walsh.
Well, thanks very much. Thanks, Andrew.